Ms. Carey.
Thank you, my lady. Professor, to cue COVID, please, are you able to just summarise briefly what it is, why you commissioned it, and what it told us?
Thank you. The point of Q COVID was to do a much more accurate assessment of risk for people dying of COVID. The immediate aim was to help to make the shielding list a much more accurate tool, and based on individual risk, including things like ethnicity and deprivation. So it wasn't just on individual diseases, which the previous list had been. It subsequently became arguably even more important in that it helped us to identify people who had accelerated vaccination when that happened. So it had two uses in practical terms.
Pause there. Did it, in fact, identify a further 1.7 million patients who ended up being added to the shielded patients list?
Correct.
And was it as a result of the work that Q COVID had undertaken that you and your fellow CMOs decided that Down syndrome should be added to the CEV list?
That's correct.
I think that was according to your timeline, that Down syndrome was added in September 2020.
Yep.
The additional 1.7 million were added in February 2021. And I suppose it begs the question, do you think, therefore, perhaps that was too late for that rather large cohort of people who should have been shielding?
Yeah, I think the first thing is to acknowledge that this was extremely difficult to do because it involved data from multiple sources. But the big delay in this was actually principally in being able to pull the data from multiple sources together. And I think, again, if I may make a suggestion for something you might want to consider for a practical solution, the ability rapidly to get data from multiple sources is absolutely critical to these. So, for example, good ethnicity data would be held in one area and death data might be held in another area. You've got to be able to, in an emergency, pull these together very fast. And only if you can do that can you end up with accurate risk stratification based on individual risk rather than very broad categorizations.
Do you think that the addition of so many people in 2021 erodes or undermines the credibility of those that were asked to shield back in March 2020?
No, I certainly don't think so for the ones who shielded in 2020. Of course, it was very difficult to work out whether the risk, individual risk for people who had shielded because they were in a different category already. So that is a weakness of the way we did it in two stages, but I don't think there was an alternative to that. But I certainly think it was reasonable to have a first pass and then sensible to have a second, much more individually based risk subsequently. All of us would have preferred to been able to do that a bit faster.
I think you say at your paragraph 9.23, of the 1.7 million Q COVID cohort, 86% had an ethnicity recorded, of whom 36% were non-white, compared to 17% of non-white ethnicity recorded in the adult population. Just help me with that in
I think
lay speak.
Yeah, in broad terms, what that means, and this is unfortunately unsurprising given what happened, is that people with from ethnic minority populations were overrepresented in the population, first point, but secondly, that we didn't have complete ethnicity data, so even putting data from multiple areas together, we didn't end up in a place where we were able to say with confidence what self-assigned ethnicity was for everybody. And ethnicity is a complex issue, but obviously the ideal is self-assigned, where people have identified themselves which ethnic group they belong to.
Sorry to go back on it. Could I just ask, going back to the suggestion for a possible recommendation, how would you gather the data from all these multiple sources? I mean, what are we talking about here? Are we talking about systems that speak to each other? Are we talking about getting permission to share patients' data? What do we need?
In this situation, this was not based on individual patient consent, because that wouldn't have been possible to do at the scale we're talking about and the speed we're talking about. But you also have to be very careful, of course, that you only provide in exactly the data you need and you're not overstretching the mark. But some bits of data were held in GPs, some were held in hospitals, some data came from other sources as well, and you need to be able to pull those together And there are two elements to that. There's a technical element, which is increasingly easy, actually. There are lots of ways of getting one database to talk to another. And then there is a legal and societal issue, which is, do we want to do this? Now, I think under all ordinary circumstances, the expectation level, I think, of legal barriers to it is high, and that's a societal choice. But in an emergency, the ability to, within the law and within parliamentary consent, merge these data sets together, the faster you can do that, the faster you can start to provide accurate information that helps to identify those who are most at risk.
Thank you.
And
There
I
are
will
variations
slow down,
of-
apologies.
No, it's all right. There are variations across the UK then as to who was added when it was paused, stopped. And I'm just going to ask you about 15th of September 2021, the shielding programme closed. Is that correct?
Correct.
Whose decision was that?
Well, because I'm pausing, I can say with confidence, not mine. I can't remember. I think that was a sort of a variety of people came together. But by this stage, I think it was reasonably clear, given the much lower mortality and the fact that almost everybody who chose to was double vaccinated by this stage, that the disbenefits of being shielded, which are isolation, mental health issues and others, were likely to outweigh the benefits for virtually everybody.
Did you have any involvement in putting support in place for those who had been shielding up to then and therefore were no longer shielding?
No, I mean, I said there were three elements. There was the conceptual, was this a good idea, which SAGE led. I was co-chair of SAGE, so I can absolutely speak to that. There was the who is in the greatest risk, which we've just spoken about. But the actual delivery of this was done by other departments, actually, not even other bits of the Department of Health. It was done by the local government, communities department, and by DEFRA, who I think did a great organisational job. But that was a completely separate issue. And then there were issues of financial support for people who otherwise would have been working.
I'd like to ask you about support there, because I think you received an email, one of which we've got in our bundle. Can I call up on screen INQ 74822? And in February of 2022, you were emailed by someone who had been on the deemed clinically extremely vulnerable. And if we could go on to the second page, once he set out that he was one of millions who were CEV, he says in that, I say he, maybe a she, they say in the document that they followed the instructions rigorously, that meant for them sacrificing contact with family, young grandsons, reducing their previously busy and fulfilling life to a miserable and empty nothing. And if we go a little bit further down the page to the paragraph that starts, and still nothing, he says, and still nothing, no information, no perspective, no parameters. Instead, it's simply been announced that all restrictions will be ended within the month. We've not heard from or seen either yourself or Mr. Vallance for months. You seem to have disappeared entirely, and your advice and knowledge either ignored or suppressed. I, for one, am angry, resentful and fearful. Am I and the millions like me to presume that the government and the health authorities have simply decided that we are not worth keeping informed? How do I go about making a practical assessment of the risks to myself of the ending of restrictions? I feel entirely disregarded. I assume that wasn't the only correspondence.
No, I mean, I tried to make myself relatively available, so people email me on multiple different routes. And this was typical of quite a lot of people who'd been shielding. I think it demonstrates at least two things, probably more. I mean, the first of which is that although shielding had some very important, at least conceptual advantages, might come back to the evidence base of that subsequently, but the reasons for it were sensible in concept, and I thought was executed reasonably well when it was set up. As an outsider, I thought it was an extraordinary logistical exercise. It had some real disadvantages of people's loneliness and mental health, which this gentleman, this person, I think lays out really clearly and I think entirely compellingly. And then secondly, I think this was a period when there was much less information in the general public. I mean, Sir Patrick Vallance and I only appeared in and TV if we were asked to by the government. It wasn't a choice. They choose to or they don't. This was mainly, I think, an issue of you cannot over-communicate in a situation like this where someone has been essentially taken out of society and information is very important. I tried to get and then signpost to people some information myself, but that's clearly an inadequate and hopeless way of trying to achieve this aim.
Can I ask you about one aspect of this email, is the reference to making practical assessments of risks, or risk assessment, to put it another way. How were people who had been shielding and then were told not to practically work out whether they were at risk now or lower risk or higher risk? It just seems very difficult. What thought was given to helping people who were advised to risk assess how practically to do it?
I think there was a lot of debate about what the best thing to do was and what was useful centrally, which tends to lead to very crude risk classifications, and what was done best locally, i.e. via GPs or others who actually have a better understanding both of the local situations and the individual's risk. Those two are potentially synergistic, but they have to operate together. The problem for people was lots of people who, when shielding ended, continued for practical purposes to shield for quite a long period afterwards, even when we actually made increasingly strong statements saying we don't think that this is now necessary. I think people felt that they were at significant risk if they went out, if they met people, if they had other social interactions with inevitable negative consequences.
Well, quite, because it occurs to me that there may have been pockets of infection in various parts of the country. So how were they, in an area where COVID was rife, to work out what they should or shouldn't do? I think it was a difficult ask.
It was a very difficult ask. I think there was a period when the government had a system called tiers, which was discussed in the last module. During that period, and you referred to it before the break, there were areas, for example, that were in shielding. Either they didn't leave it at the time others did, like Leicester and Blackwood and Darwen, or they went back into it for practical purposes, as, for example, London did earlier than others. So at a sort of varied macro level, there were points when there was local difference. But it's not just the local difference, it's also the individual circumstances. How much potential benefit is this person getting, and also how much risk are they and damage are they accruing? And that's going to vary very significantly from person to person. That really can't be captured by government advice. That has to be more tailored.
I think you set out in your statement attempts to consider the effectiveness or otherwise of the shielding programme. And can I ask you about that? You say the Office of Chief Medical Officer did not directly undertake evaluation of the effectiveness of shielding advice. It is not possible to assess the effectiveness by reference to the numbers of people hospitalised because of various confounding factors. But I'm going to ask you about the effectiveness or otherwise of the shielding programme. Do you think it was effective at protecting the most vulnerable members of our society health-wise?
I think it was beneficial in one way, harming in another way, and uncertain in a third. The first one is for people who would normally have said, I'm a great risk and I wish to isolate myself, excuse me, which is a very natural and proper response and would have well preceded COVID. That's something which has happened in multiple infections. People who are at greatest risk choose to reduce their social contacts. It did provide a practical level of support from the government, which otherwise would not have been present. So both financial and providing food, providing medicines, providing some levels of support. That bit, I think, was a good thing. I think I'm reasonably confident that was a sensible thing to provide. I think my view is that it is likely that, well, the second bit, which is clear, is that there were significant harms to shielding, which your last email that you showed up, I think, is a very good testament to. And then the third element, of which is, did it actually lead to a reduction in infection and therefore a reduction in mortality, is extraordinarily difficult actually to test. because the group of people who were shielded were by definition at massively greater risk or substantially greater risk than the general population. So if they got COVID, they were much more likely to die. That was the reason they were shielding. And they often were also people who, because of their care needs, were likely to have multiple contacts that others wouldn't, making the incidence, how many cases there were, also difficult to tell. If it would be helpful, I can give a slightly more technical answer, but that depends whether that's helpful.
Well, can I ask you about Professor Snooks's conclusions, and then we'll consider whether we need to descend to the technicalities. Could I have up on screen, please, 474285_52? And I think you are aware, Professor Whitty, that Professor Snooks has considered some of the evidence and evaluated some of the evidence on the efficacy of the shielding programme. And she concludes at her paragraph 147 and 148, there is no evidence of overall reductions in COVID-19 infection associated with shielding, except in the subgroup of rheumatoid arthritis. There is evidence that hospital-acquired infection was higher in the shielded group, as the mechanism for protecting clinically extremely vulnerable people from serious harm or death during the pandemic is to avoid infection. These results cast doubt on the effectiveness of the shielding policy. She makes the point there is little high-quality evidence on the impact of shielding on mortality, but those researchers that have investigated this have not found consistent or sustained effects. In the majority of studies, mortality has been found to be higher. And she goes on to make the point, of course, that you can't know what would have happened if we didn't shield.
Yep.
But can I ask you, please, do you agree with those conclusions set out there or not?
Well, firstly, I heard that Professor Snooks has just had a medical event, and I'm very sorry. I hope she makes a rapid and full recovery. I mean, she contributed very importantly to the literature of people trying to study this, and her own papers are extremely caveated and make clear the methodological difficulties. And I thought, actually, her expert witness summary of the various evidence was a sensible summary of a complex and rather confusing field. I was quite surprised that she came out with such a strong statement, having come up with such a nuanced set of reviews of the various areas. And I think what I am going to make my technical point, actually, because I think it's important for actually understanding this. In these kind of epidemiological studies, observational studies, what you're trying to work out is the difference, whether a particular exposure leads to a particular outcome. That's simply what it is, exposure and outcome. But there are a bunch of what are sometimes called confounding factors. Those are things you can measure and you can deal with in analysis. But there are other things which are called biases, which you simply cannot deal with by an analytical means. And if you've got a bias in a study, it is essentially going to be very difficult to interpret through to worthless. That's the reality. The difficulty of studies is never finding the exposed group, it's finding the control group. And if the control group is systematically dissimilar in every way from the exposed group you're interested in, then it's basically impossible to actually draw a conclusion. My view is this is, to use something you discussed with Professor Smith yesterday, absence of evidence one way or the other, really, rather than evidence that this did not work. I'm not excluding the possibility that it didn't do what we were intending. I'm not saying that it was highly effective. Certainly not saying that. But I just think I wouldn't go as far as Professor Snooks has in the way she's interpreted in this summary. As I say, the rest of her analysis and her own studies I consider very nuanced and appropriately caveated. I'm sorry that was a bit technical, but I thought it was sensible to do that.
No, so I suppose it comes to this. In the event of a new pandemic, would you devise a shielding programme again?
Well, I think there are two things I would definitely do. I think shielding, I'm unsure about. It would depend on the situation. I definitely think that the risk stratification is really important because there are many other things that flow from them. And indeed, you don't know what will flow from them always when you do it. So we didn't actually know that Q-COVID would end up being extremely important to help us with vaccination prioritization. And secondly, I do think it's important to put in place a mechanism to support people who rationally have chosen to take themselves out of society to the best of their ability to protect themselves. Whether the particular approach to shielding we took is an appropriate one to use again in a respiratory infection, I honestly don't know. I think it's going to depend on the situation. There are many kinds of pandemic, of course, where it would be completely irrelevant. It wouldn't have helped in HIV, for example, or many other important pandemics. I think it does, and my final point, and I'm going to give it a third kicking, and then hopefully I've done my kicking for it. It demonstrates yet again why the Great Barrington Declaration approach, where you say you can shield the vulnerable and leave everyone else, makes no medical sense, because shielding someone from a respiratory infection is extraordinarily difficult to do. People tried really, really hard here, as you can read from that email and many others that you will have seen in your testimony. And it is important to note that even there, with a highly transmissible respiratory infection, very, very hard.
Yeah, I suppose one of the points she's making there is if you don't get nosocomial infection under control and you have clinically vulnerable people who need to go to hospital to manage their underlying infections, it's a pretty dire situation for them.
Well, I think I'd go further than that, actually. That was part of the logic of shielding, was we knew that inevitably there would be infections at a higher rate in hospital than out of it, and part of the point was to ensure that people who were at the greatest risk didn't go into hospital at the point of the peak epidemic.
In relation to the Great Barrington Declaration, for those who haven't followed, was that October 2020?
I can't remember the exact date.
It was the autumn of 2020.
Yes, but its basic concept was you could shield some people and then let the population, the infection die out of its own accord through others. I've given quite a long critique of it to the inquiry previously, but I'm sort of, in a sense, evidencing the points I made previously.
Finally, this on the CEV. Do you think that there should be more advanced planning to help identify either those that might be at risk? I suppose that depends on the type of virus that you're dealing with. Or is there anything you can think of that we could do to help plan a shielding programme in the event that it were needed?
I was actually, in this situation, pleasantly surprised by how quickly NHS England, through its digital systems, was able to identify the people we had highlighted as high risk. So I actually thought they did a great job, and that was obviously pre-done. That wasn't done during the pandemic. For the specific risk, though, the Q-COVID kind of model, absolutely, you could not do that until you know what the specific risks are. So that has to happen, unfortunately, once you've already got some real data.
Clinically vulnerable people, please, Professor. I think, can I show on screen the guidance INQ 348029? This was the guidance that was disseminated on 16th of March of 2020. And I think the list of those that are required is set out, forgive me, I just turn up my tab, on page 2 or 3 of that document. Page 3, please. Now, this is a different category and a wider category. Is that correct? And I think you say in your statement the clinically vulnerable group encompassed approximately 17 million people who were eligible for the vaccine and therefore potentially asked to socially distance.
Yeah, so specific, this was, for practical purposes, the same list as for a flu vaccination.
Right.
For those who are not, haven't reached the age threshold. And that was for practical reasons, but we thought that the risks were likely to be very similar, and they knew that they were eligible for a flu vaccine. So in a sense, it was a group that was pre-identified, and you could simply translate that across.
Right. Okay, so it was 70 or over, under 70 if you had various health conditions, or those who were pregnant.
Yes.
All right. And they were asked to socially distance, and indeed, if you go down to page 4, please, the guidance sets out there the various things that were asked of the clinically vulnerable. Now, can I ask you about pregnant women? There were a number of pregnant healthcare workers who clearly will have read this, and in accordance with the guidance, were now being told to work from home where possible. Was there any consultation with the Royal Colleges, either Obstetrics and Gynae or Royal College of Midwives, prior to the clinically vulnerable guidance being published?
Yes, there was quite a debate. I mean, I wasn't leading this. Professor Jenny Harries was. And can I just do a quick side point? Professor Harries, whenever there was a really difficult problem, she walked towards it, which is one of the reasons she appears in front of you a lot. But she has dealt with many of the most difficult issues. That was her choice. I think we all owe her a debt of gratitude for doing that. This is one of the issues where she was leading. And the Royal College of Obstetrics and Gynecology, who are obviously the experts in this area, the Royal College of Midwives, came up with others, indeed, with a joint statement about their view about where the risk was based on the limited data but the important data they had initially. And we signposted where we could their advice because they were the experts in this field. But the decision was that it was too complicated to try and put so many caveats into the social distancing information. And we did have a residual concern that the Royal Colleges had quite a clear view based on data, which I think was the right place to start, that the risk was principally in the last trimester of pregnancy, the third trimester of pregnancy. This obviously extends, and this is where the difference is, and it's a subtle but important difference, potentially into the first and second trimesters as well. I think what subsequent data has shown is that there is an increased risk probably across pregnancy, but that risk is clearly much greater at the tail end of pregnancy. So in a sense, both positions were a reasonable position to take, given the limited data that was here. We tried to make sure that there was no conflict, but there remained, I think, some ambiguity here.
I think you've seen an email from the Royal College of Medicine being critical of you for not...
Royal College of Midwives.
Sorry, Royal College of Midwives, forgive me, you're quite right, Professor, saying critical of you for not providing guidance for employers, saying fairly and squarely this is the job of the 4 CMOs. Was it your job?
No. It's a short answer. I think that perfectly understandably, the Royal College of Midwives, and remembering that whereas the Obstetrics and Gynecology College is essentially my professional group. They're the doctors. Midwives tend to be a different group. But quite understandably, people seemed to think early on in the pandemic that anything that was important had to be signed off by the CMOs. Yeah. Given how few of us there were trying to do a lot of different areas, I didn't think it was sensible for us to be trying to sign off every bit of guidance. I thought that really would lead to extraordinarily poor decision-making by us and or a block on the system. So it wasn't our job to do the guidance, and we didn't. But we did appreciate the point they were making, which was that there was a potential difficulty between if you passed this document and their joint document, you could say, well, what am I supposed to do? And we tried to signpost people to the expert document, i.e. the one that was jointly put out by the obstetricians and the midwives.
New topic, please. Routes of transmission. And Professor, bear in mind that her ladyship's heard a lot of evidence about this already in the preceding weeks, but I want to ask you really about the terminology, because forget the extent to which airborne or aerosol transmission played a part. It was acknowledged, I think, fairly early on there was likely to be airborne transmission. Would you agree with that?
I agree with that.
Right. And airborne, aerosol, any other variations seem to be used either interchangeably. And the droplet definition size causes a degree of confusion potentially. Do you have any views or observations to make about the terminology we should use going forward where they were dealing with a respiratory virus?
Well, some of your expert witnesses, rightly in my view, said that part of the problem comes that different people from different disciplines work in this area and use terms, in slightly different ways. And I think that isn't helpful. I come from medical background, so I tend to use aerosol and droplet. But I think actually, in practical terms, the question is it a near field risk or a far field risk? And that is, I think, in a sense, that makes it a less of a almost pseudo-technical argument and into a practical one, which is, if you are more than 2 meters away from someone, how much have you reduced your risk? And if the answer is, if it's a droplet-based thing, in terms of ballistic droplets, in medical speak, you've reduced it to, for practical purposes, close to zero. If there is still aerosol transmission, and that is going to be much further. And secondly, it has an importance in terms of time. So droplet risk is only important for the immediate period after someone has actually been in the place, aerosol, for, again, using the medical terminology rather than the engineering one, is important for a period after that and can be for downwind of that. So I think it's often easier just to use the, okay, what is the practical implications starting point rather than the theoretical basis of it.
Do you think, therefore, there is a need for the IPC guidance to be effectively redrawn to draw up that near-field, far-field distinction?
I think it's a lot easier for people to understand and avoids these, you read sort of droplet sizes and try and work out what you're supposed to do.
Can you help me with whether at any point during our relevant period you came of the view that aerosol was the dominant route of transmission of COVID?
I am still unsure whether it reaches that level of importance, but it is certainly substantially more important than we with collective view was right at the beginning. And I don't think any of the evidence you've heard would dispute that the midpoint of medical and scientific opinion undoubtedly shifted over the first year of the pandemic. There were people who were outliers on both ends of the argument and indeed still are, but in terms of the midpoint, that shifted during that period.
Given that it was acknowledged that it was possible, the extent of airborne transmission was not known, do you think at the start of the pandemic in March 2020 there ought to have been FFP3 recommended for those working within the healthcare system?
Well, I think that hinges on a number of things, but I think that includes how frequently a situation where an FFP3 will make a difference compared to a surgical mask, if there is a difference. And the second question is there a difference at all? And you saw the evidence both of Professor Hopkins, who I would consider one of the leading health protection people in Europe, and your own expert witnesses who agreed with her the next day that actually the evidence that there is a difference between these forms is in fact extremely weak. That it may develop over time. That's not to say it doesn't exist. No. It's simply that at this point, now, then the question is, are there any downsides to wearing an FFP3 compared to wearing a splash-proof surgical mask? And the answer is pretty clearly yes. And they form two groups. And there's one group which you've dealt with quite comprehensively, which is the disadvantage to the individual. And I thought it was interesting that what your expert witness said, that when they introduced them in their hospital, people who'd be complaining they wanted them now complain that they didn't want them because they were so uncomfortable. And I would encourage anyone who doesn't believe me to try and wear an FFP3 all working days, day in, day out. It is not easy. It is very uncomfortable. But it's also an additional barrier between clinicians and patients. And patients, I think, sometimes get a bit lost in this. Every layer of PPE can potentially protect healthcare workers. That's the principal goal. But it can also protect patients under certain circumstances. That's also a co-principal goal. But it also provides a barrier between the clinician and the patient. If a mask at all does that, it's much less easy to communicate. FFP3 is harder to hear through. It's harder to express emotions through. Again, there's weak but reasonable research evidence, but it's observationally true. And I worry, I have to say, and I wasn't involved in these, I'm trying to just expand because I think some bits of the debate were well covered previously and some bits were not. If you are hard of hearing, if you've got early dementia, if your first language is not English, actually having people unable to speak clearly and unable to express emotions does have downsides for the provision of care. I'm not saying that overweighs it, but I think people have talked rather loosely of, quotes, the precautionary principle. As previously, I consider that is only a useful principle where there are no downsides. Otherwise, you're talking about balance of risk, and balance of risk is a different concept.
Quite a lot to take in with that answer, Professor, but let me just ask you about that. We've heard about the discomfort, and in fact more than discomfort, the actual physical marks it leaves on people's faces, the dehydration and the like. But one of the things you say in the technical report is that IPC there helps workforce morale, it supports and reassures clinicians. So forget the science for a moment. If the workforce felt more reassured by wearing FFP3, is there not an argument for enabling that to happen, supplies allowing?
Yeah, so I think, so firstly, I completely agree with the point, which as I wrote it, is probably
Not surprising.
And I think that one of the things we got wrong early on in the pandemic is the communications, and I think it goes back to my previous point about confusion, communications within the medical professionals who were giving IPC advice and those who were having to work on the front line meant that there was, I think there was, through a combination of shortages of supplies, which were certainly felt locally, even if they weren't true at a national level, they were certainly true at a local level, plus a concern that the reason that people were giving advice was essentially because of shortages, plus a concern about were they being given adequate protection given the very big risks they were facing. And you heard what Professor Fong was saying, you can see entirely why people get to that. I think that was not as well handled as it should have been, and we should have predicted that and done that better. There's no doubt about that. I talk about we collectively rather than we.
Can I pause you there?
Yeah,
I know you're mid.
I'm getting to your answer, but I'm trying to explain the reasons for it. But so therefore, I think that what Professor Smith put in place with his colleagues in Scotland and what was advised by Professor Hopkins in her evidence to you is correct, which is it is sensible to say to people, our advice is professionally we don't think this makes a difference, but if you feel this is important for your particular situation, this is available for you. And that might have been tricky right at the beginning because of what was available in the country at that point. But I think in principle, that seems to me a reasonable position to be. The counter-argument to that, and I'm giving a long answer because you've gone over this ground a lot of times, and therefore I want to give you a complete answer, is that some people want to have some freedom to be able to go up above where they want to be. The counter-argument, if you've got stocks that are available everywhere, so leaving aside the zero-sum nature of this, if there's a shortage of stocks, is that quite a lot of people actually want to be told, can you just tell me what it is I'm to do it, and I will do it. And so some people prefer the one and some people prefer the other, and that's the reality. But I personally would give people choice, within reason.
Do you consider that FFP3 offers a higher degree of protection from inhalation of aerosols than FRSM?
Well, in the sense of, would I use FFP3 if I was going into a room with someone with multi-drug-resistant TB? Yes, I do. If I was doing an aerosol generating procedure in a very dangerous disease, yes, I would. Did I use FFP3 when I was on the wards with people with COVID? No, I didn't. I followed the guidance. Had the guidance been FFP3, I'd have followed that. I mean, my view about this is the guidance is usually there for a perfectly logical set of reasons. And when there's a 49%, 51% call, I'm going to go in the hands of people whose professional job this is, which isn't me, and I will follow the guidance. So the answer is I did what was recommended, not out of a point of principle, but just because I think, fine, that's what the experts have recommended, I'm comfortable with that. But people clearly weren't comfortable, and that was our failure, was the fact people did not feel, for understandable reasons, comfortable.
Well, that brings me back to something you said a moment ago. You said the comms should have been better. How? What would we do differently next time?
Well, I think that there were ultimately, as I say, I think three things which coincided. The first of which was we, of course, were managing a situation where the level of knowledge was extremely weak. So it was very difficult for anyone, hand on heart, to say, well, I'm an expert in this area, I know what COVID is, the risk is, and this is the risk, because actually there was a lot we didn't know. So there was genuine uncertainty. Second problem, and that's going to be the same the next time round. The second problem was what I referred to earlier, which was I considered there was a confusion about who was leading, at least in England, this area. I was confident it wasn't our team, but I was not clear exactly who it was, and I don't think the people involved were exactly clear, although they were all trying to do their bit. This wasn't an abrogation of responsibility. And that really, I think, made it much harder to come to a clear communications area. And thirdly, there was a real mismatch for many people in frontline and other services between being told there are no problems with stockouts and actually either their immediate experience or I think in practice more commonly, but nevertheless, importantly, second-hand experience where they would see on Twitter, they would see among their friends stories of, and they would say, well, that can't be true. And that leads to an erosion, a perfectly understandable erosion of trust. So I think these things came together, and I think, I can't emphasize too strongly that this was the area where I think that the breakdown of the otherwise incredibly unified view on COVID was most obvious within the medical and nursing professions. And I think this is clearly something we have to do better next time.
I did ask you how.
Well, I think that the first thing is we've got to have either stocks or the ability to create stocks of all reasonable PPE. Now, on this one, FFP3 is UK standard stock, but obviously for many, many smaller numbers of cases, surgical masks are obviously widely available. We weren't using gowns routinely, so that was a new departure. And of course, we practically had a situation where every country in the world simultaneously wanted a massive increase in this, and some of the countries that were producing it were themselves under strain, China, in fact, being one of them. So the result was a big increase in demand and no increase initially in supply, and that caused problems. I mean, I obviously wasn't involved in this, but I'm just making an obvious point. So having confidence that you either have the stock or can create the stock, having internal capacity. For example, Germany had much greater capacity to make than we had capacity to make. That's not just a fact. Is the first one. Secondly, I think you've got to have a system that is capable of making decisions on this, where the senior person who is the final arbiter, if there's an issue of debate, is clear from the beginning, rather than trying to work it out in flight, which is, in my view, where we ended up.
Pause there, because I do want to come back to the UK IPC cell, but can I just try and finish my thread of thought? Do you, or would you advocate for further studies to be done to determine the protective nature of FFP3 over FRSM?
I think it is sensible to do that, but to acknowledge that it would only be relevant infection by infection.
Yeah.
So you can't translate something that is in one infection to another, and you need to have quite large numbers. And this goes to a slightly wider point, which is the majority of the transmission that went to healthcare workers in hospitals, certainly, primary care may have been different, was from other healthcare workers, not from patients, and vice versa. The large nosocomial spread in hospitals between patients appeared to be principally between patients, not via healthcare workers. So actually, the evidence that the big problem for both healthcare workers and patients was the lack of PPE that was a barrier between them isn't held up by actually what was seen, which was transmission between healthcare workers. Now, if you make someone aware of FFP3, my own prior would be when they go into the staff room, whatever it is, they're even more likely to take it off than if they're wearing a surgical mask, which in fact you can wear perfectly easily and comfortably for quite long periods. So it's not, and this is the point Professor Hopkins made, which I completely concur with, the question is not what happens in a lab, the question is what happens when people are using it day in, day out in operational circumstances. And if it doesn't hold out in that situation, it's not doing a heck of a lot of good.
I follow that. But in the technical report, I think you commend that lab trials are of evidential value. We've heard of observational studies as well, tending to suggest that FFP3 is more protective than FRSM, and certainly more protective than no mask at all. And I think so Gregor yesterday said that observational studies were useful. We appreciate that the ability to do a randomised control trial may be very difficult to determine whether FFP3 is more protective. But having set this hare running, having had 20 years plus of a division between FFP3 and FRSM masks, it now appears during the inquiry we're saying the protective effect may not be quite as we envisioned. I can't help but wonder if we're making it worse for the healthcare workers now, to tell them it didn't matter when it clearly did matter so much during the relevant period.
Yeah, so I think in a sense your hierarchy is exactly right. We need to do the lab studies first, because if there's no lab difference, there won't be any difference in reality, almost certainly. We then need to do the observational studies. Trials are essentially a kind of the gold standard of evidence for clinical medicine and health protection. Trials in this area will be very difficult. They'd have to be large. They have to be what's called cluster randomized. You couldn't do them on individual basis. A variety of things that would be tricky on this potentially. And so, I agree that we need to get a much stronger evidence base. Or say we're not really clear and we think you're fine with the surgical masks, but here are FFP3s if you're at particularly high risk or you have particularly high concerns. That's a pragmatic answer. It's not a good scientific answer.
Asymptomatic transmission and asymptomatic infection, we have the difference well in mind, Professor. But in the event of a new respiratory virus, should the UK assume asymptomatic transmission until it's shown that the virus does not transmit asymptomatically?
I think we should definitely assume that some degree of asymptomatic transmission could occur. That it would be foolish to not assume that. But it is quite practically important to at least have a first pass view as to whether it's likely to be a major part of transmission. So, for example, quite a lot of our initial public health guidance was for symptomatic people, and the reason for that was to allow people who were not symptomatic to go about their daily business. Had we said everybody is at equal risk of passing something on to you from day one, we would have essentially been saying symptoms are irrelevant, we've got no test for you, sorry. So what you do then, you practically have got some very, very serious societal answers, and the same would be true in the health system. So I'm not saying that it's not reasonable under certain circumstances to assume under all circumstances to assume it may well occur, and under some circumstances it may well be the prior view should be this is likely to be a major part of it. If we have another COVID-like infection, I think we would now start from the principle that asymptomatic transmission is a significant part, as opposed to starting from the MERS and SARS environment where we started with, actually, this is unlikely to be the case. So I think we've now moved our starting point, that we shouldn't assume that that is a cost-free decision. It is not. It comes with quite significant societal and other costs.
UK IPC cell guidance, I just want to touch on it very briefly because you probably covered it in part. But you're not the sign-off, if I understand your evidence correctly, for the UK IPC cell guidance.
Correct.
All right, now we heard a little bit of evidence about the senior clinicians group, and I'd just like to hear from you, please. What role, if any, did they have in amending, looking over, approving, being cited on, whichever terminology you want to use, of the CELS IPC guidance?
The UK Senior Clinicians Group, can I say a little bit about that because it makes more sense than my answer?
Yes.
It was something which I and colleagues set up, I chaired, between the senior clinicians in government across the 4 nations. And it was explicitly not a decision-making body. That was in its terms of references. It was not a decision-making body. And it really had 3 functions, one of which was information exchange, the second of which was essentially mutual support, which, these were, for many people, lonely and difficult jobs. But the third one was to allow people to discuss difficult technical issues with their peers. That doesn't mean the group takes the decision, but it means that you can then have a robust discussion amongst people who are all experienced and all decision makers in some field, and then the person who is the decision maker takes it back to make the decision in the place they should. So it's a form of peer review, and on at least 2 occasions that I can remember, IPCC discussions were escalated to this group for a discussion. There was quite a strong discussion. Almost invariably, that happens when it's a 49%, 51% call. So if it's obvious what to do, you don't escalate it, you just decide. Right. But these are ones where people were unsure and they wanted to get to check in with other people and see what their view was.
Was one of those the acute shortages IPC guidance?
So the acute shortages protocol, yes. And where the question really is it better to take the risk of running out of PPE completely and keep people as they are, or to try and reuse things with the risks that go with that, but the result of which is you have a high probability you'll run out, you have a much lower probability you'll run out. And that's a debatable question, and that was debated as one of those things.
In relation to the senior clinicians group, you say that it brought together initially OCMO, Public Health England and the NHS, and was expanded to include further clinicians, including the other UK CMOs, and you generally chaired the group. Why were the other CMOs not involved from the outset? Its initial point was on an England-wide basis. We started off with the medical director of the NHS, the chief medical advisor to Public Health England, as then was, and me, as the senior clinicians in each of the areas of government. It soon became obvious to us that this was a useful forum. And since quite a lot of the decisions had to be taken on a four nations basis, and also, importantly, other CMOs, other chief nursing officers had other skills. You've heard this from some of my colleagues. So it both broadened the geography, but it also broadened the skill base. And they, of course, also were in lonely positions, and it was useful for them to have the support. So I thought there were several reasons that was helpful. Final question in relation to the IPC guidance. We saw a CAS alert that you issued. I think it was sending out the acute shortages guidance actually at 4:43 on a Friday afternoon, and you may have heard other people speak about the late dissemination of guidance. It came through your office, obviously not from your office in terms of the guidance itself, but can you help from your perspective, particularly being on the ground doing the shifts as you were, as to is there ever a good time to publish the guidance?
First just on the technical point, CAS alerts go through my office. Some of them I sign and some of them I don't. If I sign them, I've agreed them. If I don't sign them, it doesn't mean I don't agree them. It just means it's not from me, just a technical point. There is a absolute damned if you do and damned if you don't on this one, where on the one hand, if you do it on a Friday afternoon, you are guaranteeing chaos. And if you do it on the Monday and people have run out of PPE as a result of that, they will legitimately say, well, you made this decision last week and you didn't tell us till Monday. So it's kind of, you can see where the difficulties come. However, I think in this case, I think our view was, having looked at it, we could have issued it earlier at a bit more risk, and I think that would have been the right thing to do, or to probably to have held this one over. So I'm just making the general point, but I think you should avoid, I think the implication of what you're saying is completely right. You should absolutely avoid issuing guidance just before a weekend. Subsequent modules will come across situations where we took the reverse decision and have also been criticised for that. So just to be clear, these will never be straightforward.
But, I mean, during a pandemic, so many people were working a 7-day week. Was there such a thing as a weekend for most people?
Not,
to whom this alert was going?
Yeah, not in terms of the clinicians who are working on the ground. Absolutely not. People work all the way through, and a lot of people were working a 7-day week. Nevertheless, the system tends to be better. Everybody tends to be in their place Monday to Friday. Large numbers don't. But if you've got 6 people who need to sign off on something and one of them's not there, then you can slow things down. So I think the challenge to us, did we do the right thing on this, was a fair one. But you're also right. A huge proportion of the system was working all the time.
I'd like to ask about risk factors, please. And can I have up on screen 410237_44? There were, as the pandemic demonstrated, a number of people at higher risk than others of being infected and or dying. I'm not going to ask you about each and every one of them, but if we just look at the infection fatality rate, and once you start to look at the figures for the 60 plus, 70 plus and 80 plus brackets, a significant jump there. And if we go, please, to page 45, the proportion of people infected that were hospitalised, again, look at the 60 plus range, significantly higher numbers there. And again, I'm afraid for the fatality rate for hospitalised people, again, significantly grim numbers as you get older. Do you think the risk to elderly people was significantly well publicised at the start of the pandemic?
Yeah, I think of the risks that became apparent over the pandemic, this was both the biggest by some distance, actually. This trumped all other risks pretty well. it was also the first to be identified, and I'd like to pay tribute to Chinese scientists and clinicians who did so. And then the same was true in Italy. So by the time it hit the UK, we were already aware of this risk. You can see the date of this. This is before our wave was fully underway. So this was identified, and I do think this was identified in the public. The bit we were a bit more cautious about saying, but fortunately did prove to be the case, was the other end of the age scale, where initial data suggested that children were relatively unaffected, in contrast to something like pandemic influenza, which would definitely hit children as well, particularly the youngest children. And that did, fortunately, prove to be the case. That doesn't mean there weren't children who didn't become very sick acutely, chronically, and some tragically died. But it was a much lower risk in that group. The older age, I think, was both certain and publicised quite early on.
The risk to ethnic minorities we've touched on, but can I ask you please about the report beyond the data? And while we call that up on screen, it's 176354, page 14, please. This is a report, I think, that was commissioned by you. Is that correct, Professor? Just in a sentence or two, why did you commission this report?
Well, I was very concerned, as many others were, that there were some groups who were either likely to be at greater risk, and we needed to test that question, or where there was strong evidence from early observations that they were at greater risk, some of which were predictable, linked to poverty. I'm afraid poverty is a risk factor for infections everywhere. Some which we had not predicted, obesity would be an example, and some like ethnicity, where we thought there was a reasonable chance, but it was a more complicated area. So there was a quantitative element to this, where we tried to identify what the level of risk was for different ethnic groups to a reasonable degree of granularity. So not, for example, just South Asian, but also people who are British Bangladeshi, British Pakistani, and so on. But then this was also aiming to put those data in context and ask, why is that? What's the driver of that? Because that's quite important for what you then can do about it.
Can I ask you, please, if you are able to answer sets out the review questions that the report was aiming to answer. And if you can, Professor, can you help? Are individuals in BAME groups more likely to be tested for and or subsequently diagnosed with COVID-19? What was the outcome of the report?
So the answer for each of those two, and I'm also incorporating more recent data but it was in line with what was here. They were not more likely to be tested or less likely to be tested, the exception being people of Chinese British ethnicity, just to be for a detail of precision. But they definitely were at higher risk of being diagnosed with COVID-19 infection. This difference, though, was different between the two first waves. So in the first wave, people of black ethnicity were particularly high risk of being diagnosed. People of South Asian were at increased risk, and in the second wave, that reversed. So the risk was greater in people of South Asian heritage. That was largely to do with where the waves were at their worst. So in the first wave, London, which is a very large proportion of the British black population, and the second wave, the Midlands, where a higher proportion of the British Asian population live.
I think, did you say there then that question 2, are the individuals more likely to develop severe clinical presentations?
Yes, and the answer here, unfortunately, was also yes. Okay. This is quite different biologically. So this is someone who's already got an infection. Are you now likely to get a bad disease? And there were higher rates in people of ethnic minority groups, some of which were for predictable reasons, like higher levels of diabetes, but many of which were not.
Is infection with COVID more likely to lead to mortality within BAME groups?
Yes, that was clear from wave 1. In wave 2, as I say, I made the point about slight differences between the different ethnic groups and the different waves. But the short answer is yes. I can give numbers to each of these, but the
it's in the report,
answer,
and I'm afraid time precludes us from going into that. Question 4, what are the social and structural determinants of health that may impact disparities in COVID-19 incidence, treatment, morbidity and mortality in BAME groups? I suspect there are many, but can you give us an answer to that?
Yeah, so this in a sense was the key question which this report was answering, which the previous reports had not. It's the why questions. A lot of this could be explained by things like occupation, like poverty, like crowding, like living in urban settings. There was lower levels of COVID in the first two waves in rural settings than urban ones. But that could not provide the full explanation. And so there was clearly an additional element, and this was trying to tease this apart. I could give a long answer to it, but the short version is that there are some bits of this we could clearly do something about, and there are other bits that were much harder to do with structural issues in society, and indeed, arguably, structural racism in some bits of the system. That was what this report suggested. In terms of treatment, this can broadly be divided into treatment seeking. Are people being properly informed so that they seek care at the right moment? Are the treatments being accelerated fast enough through the system, or is there a failure to recognise early on? And should the treatments actually be different because there's biological basis for that being from different ethnic groups? And it was able to answer those questions less well, I would say, than the first set of questions. And then mortality and morbidity are beyond that. I can go into them if you want.
No, but can I ask you this? This is a report that came out in June 2020, I think. And as a result of this, are you able to help with any interventions that you brought to bear to try and mitigate or in some way address these risks?
Well, I think exposing them was in itself very important, because I think it highlighted to people in the healthcare system the particular vulnerabilities that people from ethnic minority and indeed some other protected groups were in. The second thing was Kevin Fenton, Professor Kevin Fenton, who was the person who led this study, then did a lot of work making sure that it was in front of, for example, mayors, so they could look at local issues, but also, for example, occupational health groups, so that people were aware that these were issues that were particularly high risk for particular ethnic groups or particular other high-risk groups. So I think Professor Fenton did a really good job on that. We also launched a number of research studies under the NIHR system better to understand this, both from a biological point of view and from a social point of view, because in a sense, unless you can understand the drivers, it's very difficult to tackle the underlying problems.
Can I just ask you about that, Professor? Because it may be suggested that, in fact, the disparities or the disproportionate impact on BAME communities in particular is nothing new. And that having more research, having another report, saying things like we need better comms, it all sounds very good, but it doesn't actually practically help the person who is BAME, who might be living in a socially deprived area. I'm trying to sort of understand what practically can be done next time to help reduce what is probably going to be an obvious disparity.
Well, I think you're obviously precisely right that some bits of this are A, predictable, and B, unremediable. In the immediate crisis of a pandemic. So you should, if you want to do something about it, you should have done it over many years previously, and that's just a practical reality. But the point about doing the research, the point about trying to pull these issues apart, is it can also identify some issues which you actually can do something about. That's the point about it, really. So, for example, we identified that people who were front of house staff, people who were public transport, taxi drivers, were overrepresented in these groups, and we would therefore looked at those environments and thought, what can we do that would reduce the risk of these environments, because we've clearly got a problem on our hands, for which solutions are potentially possible.
Understood. But what about the BAME healthcare worker?
Well, I mean, that is one of the reasons that we want to talk to the occupational health groups. But the main risk to BAME healthcare workers was much less easy to deal with by these relatively mechanistic things. Some of the risk came from living in communities where there was higher incidence, particularly in the first wave. And that's just an inevitability. There was a legitimate and perfectly reasonable discussion about should we be doing particular sets of, for example, PPE for people of different ethnic groups, taking people from different ethnic groups even out of the workforce altogether. These raise really quite difficult questions, including, in fact, in the second case, was this going to disadvantage people from ethnic groups because they'd be excluded from work, excluded from a variety of other issues. But it did at least mean that people asked the questions and were trying to work out were there equitable and helpful solutions to them.
There is further detail about this, the limitations. There's an issue you raise in the report about data capture in relation to ethnicity that's set out in the report. I'm not going to ask you about that, but I just want to ask you this. You, in your technical report, make reference to having tailored communications. And it made me think, was there any example you can give of a good tailored message in relation to the disproportionate impact on the BAME community?
Yeah, well, I mean, it's obviously you have to start off with the bad and move to the good. I mean, initially we started off with an almost exclusively white group of people in front of podiums through the BBC speaking in English. I mean, yeah, I was one of them, not criticising that in itself. So the message, the people giving the message were as important as the message itself. There was also, we were slow off the mark, and I've said that in my report, in terms of translating into many of the languages which are commonly spoken in the UK. We were slow off the mark in identifying that sources of information people were getting, for example, from radio or TV channels from overseas. So they were actually not getting any of the messages we were giving through our channels of communication. So I think we did get a lot better at it over time. The biggest, I mean, the easier ones to fix, in a sense, were the ones I've just highlighted, because you can do those centrally. I think by far the most important was actually in people who were having, and Kevin was an example, discussions with community leaders, with people who were voices people would listen to, and actually would feel much more affinity to than what they would see as potentially alien or even automatically distrusted authority figures who were really not the right people to be giving messages. So the messenger was as important as the message.
I have 3 discrete topics that I need to cover with you by 3 p.m. And it's not to do them any disservice, but can I just ask you briefly about AGPs, please? In your technical report, you say that the question of what procedures were deemed to be an AGP or not was probably the biggest source of tension amongst the healthcare profession. And it leads to the question, does it not, Professor, how is that to be resolved before the next pandemic?
I mean, I think we need to look at this because this was not specific to COVID. This was actually a much more general point. And I'll use 2 examples, one of which in both of them I made some intervention. I mean, the first one was, and I've got it in the bundle, I'm not going to refer to it, where the British Society of Gastroenterology and various others said, look, we don't agree with judgments that have been made about whether endoscopy was an aerosol generating procedure. My view on that was the initial technical advice was reasonably done, but the challenge was also a reasonable challenge from a respectable body and should be taken seriously. So we then set up a mechanism so we didn't end up with a computer says no approach for people to be able to challenge these. So I thought that was a helpful intervention. And on gastroenterology, my view was a priori, top-end endoscopy was likely to be more risky than bottom-end endoscopy, but I won't go into the graphic details of that.
No.
The second one, which I think is a more fundamental one, and we really have got to come to a conclusion about, was around CPR. And the reason for that is you absolutely do not want to put someone doing emergency resuscitation at risk, but a delay of even a large number of seconds, certainly minutes in that situation, also puts the patient who's collapsed at significant risk, and that may be a risk of death or it may be a risk of brain injury. And therefore, you don't, on the one hand, want to not have protection if that is needed, but you do not want to have something which is going to delay things if it is not needed. So settling this question seems to me a fundamental issue. And if you look at expert bodies around the world, they have not come to a settled view. So the debate in the UK reflects the international experience as well.
That sort of begs the question, why hasn't it been settled by now? This has been going on since the beginning of the pandemic. it caused the tension that you speak about in the technical report. It caused a great deal of upset in the correspondence, many of which you were copied in on. And I throw into the mix Professor Beggs's conclusions that some of the AGPs that were deemed to be aerosol generating, in fact, may not produce as many aerosols as initially had thought. Why isn't there a degree of certainty now, 4 years on, as to what amounts to an AGP or not?
I think, to me, this seems something which internationally we've got to sort out. I mean, I'm not the person going to do this. This is not my area of professional trade, obviously. I think it is important that the people who are co-designing the research on this are people like paramedics who are actually having to do it, because they have to feel confident that the methodologies are strong enough that if it comes up with an answer they're not expecting, they are satisfied it's strong enough, and vice versa. So I think we need to do this in a way which everybody gets together and decides this is the way we're going to do it, and do it reasonably effectively. Yep.
Right. Another controversial area, if I may. We are going to be hearing next week from Professor Summers and Dr. Santharalingam. And the doctor was part of a panel of 3 experts that were asked to develop a clinical prioritization tool in the event that critical care became saturated. And I think you were at one stage going to be the recipient of any guidance and report that was prepared by that panel. In opening, I said it was pretty unpalatable to think that we had to think about this, but I'd like your observation, please, on firstly, why did you want there to be guidance? We know, in fact, the guidance didn't come to fruition because it was considered that critical care capacity wasn't going to be saturated. And do you think we should have such guidance in the event of a future pandemic?
Yeah, so I think there are many things I would do differently in the pandemic, but this is not one of them. I think it was important that the process of the guidance was considered, because had we gone up 2 or 3 doubling times, and remembering this is exponential, so the difference between 3 doubling times and where we got to is profound, we might well have been in a situation where very junior staff were having to make incredibly difficult decisions for which they were not experienced enough, and that would have been, they would have needed the support of something to do that. But absent that, and we didn't fortunately get to that, we got to an incredibly difficult place, as Professor Fong laid out. I'm not in any sense minimising it. Our view was having what is essentially relatively mechanistic system that deviates from normal practice was not appropriate. And indeed, it wasn't appropriate in the views of the people who wrote it. And the guidance is, it's perfectly open. It was discussed by lots of different groups, and it's now published in a journal. You can find it very easily on the web, endorsed by the Critical Care Society, which is the official, one of the relevant bodies. So there's nothing, this is entirely open as it should be. We didn't need it this time. Hopefully we will never need it. But to have a process where people can debate this and actually say, under a circumstance where we had a situation even worse than COVID today, and that is not an impossible situation, appallingly bad though COVID was, to actually have pre-agreed that, you may have to tweak it based on the individual things, seems to me a sensible thing to do. So I was very grateful to the people who took on this very difficult task. I thought they were excellent, and I thought what they did was a useful and sensible thing. It didn't receive universal endorsement from all the groups you'd want it to, and that's one of the reasons you wouldn't want to do it in the heat of the moment. You need to make sure that, for example, the disability groups who had concerns, that mental health charities which had concerns, actually can talk those through. So I think trying to do it against the clock, which of course we had to do here, is not the right approach to it. So I'd much rather we're open about it, have a proper discussion, and work out in the very, very strong hope and expectation we will never use this. This is very much a absolute end of the road thing.
So if I understand your evidence correctly, the reason that the guidance wasn't proceeded with was because, thankfully, we didn't get to the point where critical care was saturated. Is that correct?
The technical answer is that the guidance was explicitly, and you can read this in the guidance, it's as I say, it's published, designed for what's called CritCon 4.
Yeah.
And CritCon 4 means essentially the whole system can't offload or anything. There's a principle of the CritCon system, which I'm sure you either have heard from or will hear from, that if you get to 4, nowhere is full until everywhere is full. Nowhere is overwhelmed, rather, until everywhere is overwhelmed. And we didn't reach that. We reached the situation many places individually were overwhelmed at different points, in my judgment. But that wasn't what this guidance was designed for. And I think it would have been inappropriate to take a much more, in a sense, mechanistic, although well thought through approach, rather than proper normal practice, which is to judge an individual's circumstances and preferably discuss with them and their family. That's how this should be done in ordinary circumstances.
Do I take it from what you said then that the guidance wasn't was not pulled because it was just optically too difficult to say to people, we may have to consider this?
It had been circulated amongst perfectly openly amongst a large number of charities and pressure groups who are very good, who are very expert, and it's been published online. So, I mean, I think that's self-answering.
Stay-at-home messaging, as one of those behind the podium on occasions, do you think that we got the balance right between telling people the NHS was open, but equally protect the NHS, save lives, stay at home? What do you think about that balance, Professor?
I don't think there was ever going to be a perfect balance on this one. I am confident what we didn't do was, was to identify over and over again. You couldn't say it too often. I said it, Professor Powis said it, many others said it from the podium, that the NHS is open. In particular, if there's an urgent and emergency, life-threatening situation, you must go to hospital as you usually would. And there is reasonable evidence, in my view, for example, that the number of people who came into hospital with heart attacks was lower than you'd predict. I don't anticipate there's any reason there would have been fewer. So some of those people were staying at home who otherwise would not have done, and they would have had remediable conditions. So the bit of it, which is, did we get the message across that people should still go to hospital? I think we didn't get it across well enough. We tried. I know we tweeted, we talked over the podium, and so on. Whether we push too strongly on the messages of the risks of COVID, I think that's a much harder one, actually. So, because it was really important that people understood why, if they were going to do this terrible thing for their society, for the economy, for their families, they understood why it was, the scale of the problem. I think, actually, my experience was the overwhelming majority of people thought they were doing it for the most vulnerable in society. It was entirely altruistic. So, and that was certainly my judgment, particularly amongst younger adults, who made a decision that they were going to put their lives on hold to protect others, which I think is extraordinary.
Do you think if those that were deterred from coming to hospital had come to hospital, the hospitals would have coped?
I think that the hospitals would have been able to improve their situation. So they might not have been able to do absolutely everything they would have been able to do pre-COVID, particularly at the points of the year outside the winter pressures. But I'm confident they would have been able to do things, for example, for someone who's got a heart attack, which are not possible to do at home.
Finally, this, please, Professor. Your technical report, albeit not that we're not the intended audience for it, sets out a number of recommendations, and you've spoken already today about things you would like Her Ladyship to consider. But are you able now to give us one or two concrete recommendations, in addition to those that you've already mentioned, that you think that Her Ladyship should bear in mind in the event of a future pandemic?
Yeah, so if I bank the ones I've said as I went along, I would say that the biggest one that I think deserves slightly more emphasis, even though I've given it, is having the mechanism to be able to do research very, very fast. Yeah, ultimately, what reduced mortality rates overall from the first wave to the second wave was research and individual clinicians learning. And the second, the second thing was the prevention, the vaccine in particular. Without that, if that had been 6 months later, if the things like the dexamethasone treatment had been 3-5 months later, the mortality rate, terrible as it was, would have been even worse than that. So I think people always at the beginning of pandemics underestimate that it's actually the science that's going to get them out of the hole, not all the other things they're doing. The other things are holding the line until the science does the work, and putting that absolutely central, I think, is important. And then I think the second one, really flows from your points about ethnicity. If we're not serious about trying to tackle health inequalities between pandemics, there is no way you're going to be able to do it when the pandemics occur. So that is, part of our preparation is to reduce the vulnerability of the people we know are already vulnerable. And this will have immediate effects straight away on a whole bunch of beneficial effects on health. But then when the next problem hits, we'll be in a much stronger position. And I agree with Lord Darcy's conclusion of his recent review that we went into the pandemic in a less strong health overall state, and I think that contributed, was definitely not the cause to, but it's definitely contributed to particularly some of the disparities we saw.
Lady, that concludes my questions. May that be a convenient moment for the afternoon break.
Certainly. One more session after this next break, Professor Whitty, and I promise you we'll be finished by 4:30, so you're done for this session. I shall return at 3:10.
Thank you, my lady.
All right. Right, it's Mr. Jacobs. Where's he moved to?
Over here today, my lady. Thank you. Professor Whitty, a few questions on behalf of the Trades Union Congress. Questions are on the disparate impacts on different groups of healthcare workers. You suggest in your witness statements that the key to improving the safety of higher risk individuals was principally to optimise safety for all, rather than trying to differentiate by every risk group in the workplace. Professor, there's no disagreement from my client on that as a general principle, but would you also agree that the assessments of individual risk do play a role in seeking to address some of those disproportionate impacts?
I do agree with that, and I think the question is where you draw the line. So, for example, the existence of the clinically extremely vulnerable group is an example where we drew a line which said, actually, your risk here is so high that you do need to be treated in a different way. But what I think we were trying to avoid is a situation where every single person was assessed on completely different risks, and we ended up in an extremely difficult situation to actually provide realistic and achievable guidance, where it'd be much better for all to optimise the outlooks for everybody. So I think we're in agreement. I'm just amplifying my point.
And perhaps taking that forward, a known comorbidity is something that can be identified in a risk assessment. Some determinants, such as quality of housing, more difficult to address in a risk assessment. Is that right? If we consider the position of porters and cleaners within healthcare, part of the workforce on lower income, higher outsourced work, higher incidence of those exacerbating social and structural determinants, beyond the pursuit of a safe working environment for all, what are the steps that can be taken within healthcare to try and provide some additional layers of protection?
Acknowledging that this is quite a long way from my area of practice, so I can make some general points, but I wouldn't want to claim that this is something where I'm the right person to give a definitive answer. But I think there are two things which we can do, which we currently don't do. I think that the level of training for people who are not patient-facing in one sense, but actually are in reality, is often much lower than would be optimal. And I think ensuring that there's a minimum level of training, being a porter is a difficult job. Physically, you're also close to patients a lot. For example, people who are providing meals are close to patients a lot, and I think they're not trained in PPE to the same level. And I think, of course, they see a lot of people in quite close succession. So there's a training element. I think the second element is I worried throughout the pandemic as to whether we were dealing with the financial situation of people who were not on an employed basis, a permanently employed basis, was optimal. We know from the care sector, for example, where the data is clearer, that people who were not paid sick pay fully were more likely to come into work when they had symptoms and therefore spread disease around. So I think there are a set of issues around this which I think we need to look at quite carefully in advance of the next emergency. It doesn't have to be a pandemic.
So training and financial position, two practical steps that could potentially be looked at to try and address this disproportionate impact. Finally, you've given evidence in response to Ms Carey's questions about some of the structural determinants and health inequalities which are relevant to disparate impact. You've described how it's for society, and I hope I don't paraphrase too unfairly, but you've described how it's for society to decide whether and how to answer those in advance of a pandemic. A healthcare worker who perhaps perceives inequalities not just within society but within the healthcare service may feel that those broader matters could serve as a distraction or even excuse from taking a hard look at matters that actually exist within the healthcare service. From your perspective, taking your point that you're not directly responsible for these matters, do you think that there has been any sort of real or sufficient focus on structural issues, not just within broader society, but within the health service, that the health service can do something about?
Well, I'll take those in two parts. I mean, the first part, I would completely reject the idea that there is a tension between trying to sort out disparities in society and trying to sort out disparities in the health service. I consider those are in fact synergistic, and doing one will help to reduce the other for those who are working in the system. So I just want to be really clear about that. But on your second, I mean, the point that was made, I think rightly, in the getting behind the data, which the inquiry council, the chief counsel laid out, was this is a real. This should be a wake-up call, as if one were needed, that these problems exist within the health service as well. And that point was made, and I think most people would agree with that point. And the time to try and fix them is not in the middle of a crisis. A crisis demonstrates as a problem. Sometimes it gives a sense of urgency, but unfortunately it also gives multiple other things that need to be done simultaneously. I think that we do, between crises, need to look at these issues very systematically and seriously.
I'll leave it there. Thank you, my lady.
Thank you very much, Mr Shaker. It's very grateful. Who's next? Mr Stanton. You've gone over there as well.
Yes, my lady.
It's so that you don't have to have your back turn around to them.
Good afternoon, Professor. I appear on behalf of the British Medical Association, and I have a question for you about the harms experienced by healthcare workers. In your view, how do we ensure that the response to a future pandemic or health emergency avoids the severe and ongoing physical and mental health impacts experienced by healthcare workers in the COVID-19 pandemic, as described so powerfully earlier today by your colleague, Professor Fong? And Professor, when answering, could I ask you to consider the extent to which low staffing levels have contributed to these harms?
Well, unfortunately, the answer to the first one would take a long time, and I will give a couple of comments, but this is something which, to give a proper answer, would take more time than her ladyship would definitely want us to take. Staffing levels definitely make a difference, because if you have some degree of capacity to surge, which greater staffing level gives you, you can deal with a higher degree of emergency without stressing the system more than you otherwise would do. The difficulty, of course, in the health service is you are at any given time, there are multiple competing demands that those who are leading it, and I'm not leading the NHS bit of it, so I'm not saying this on my own behalf, but making an obvious point, have to compare to one another. And if you have high staff levels sufficient to deal with an emergency, that means some other part of the system, given the same degree of envelope, is going to be relatively squeezed to make room for that. And that's the difficult choice which political leaders and leaders of the system have to take. And I'm just being fairly clear about that. But the idea that actually if we'd had more capacity, particularly in intensive care, but more widely, that would have given a bit more headroom and therefore reduced the number of places which came to the kind of state that Professor Fong was talking about. Clearly that is true, with the caveat I made previously.
Yes. Thank you, Professor. Next and final question relates to the recording of healthcare worker infections and, sadly, deaths whilst at work. Do you agree that it is unacceptable that we do not have reliable published data about how many healthcare workers were infected while in service, particularly those who then tragically died, and that in future there needs to be a better system for recording these impacts?
A lot of the problem that came with, so firstly, data existed. I mean, every day I had data which told me how many healthcare workers had to that point died and who had died in the last week. So data were flowing. I think one of the things that were very difficult were defining what is a healthcare worker. If you're a doctor working in a hospital, then it's a pretty clear yes. But there are many people who are actually could be counted either way. And then that's before we get on to the question about where was infection from their workplace and where was their infection, what would have happened even had they not gone to work. And that's a much harder question to answer very often. But the principle that there should be data available is absolutely right for lots of reasons, but one goes back to something which my lady talked about earlier on, which is if it's one of your earliest indicators that something is wrong is healthcare workers are dying, therefore knowing that healthcare workers have died is a really important thing to do, because that can tell you at an early point that you are in a new situation which you need to do something about. So I think it is more than a kind of workforce welfare point, which it absolutely is and should be, rightly. It also is a very important point of how you actually spot trouble early on, where you have a realistic chance of heading it off.
Yes. Professor, the reason I asked the question was the Riddle system, with which you may be familiar, was clearly not fulfilling this purpose. Whilst there was a flow of data within the NHS, it appears that flow was not accurate. There was a report in 2023 that you may have seen in the British Medical Journal along the lines of a tribute to healthcare workers, and they expressed the view that their account may not be complete and invited families who may have suffered a bereavement to come forward. Now, if the British Medical Journal in 2023 doesn't know how many doctors sadly died, that tends to suggest that there's something wrong with the system.
So firstly, I recognise the point you're making. I agree with it. And I think it's important for the reasons you've given. It is also important to acknowledge every healthcare worker who's died. So I very strongly believe that. If I may make a hard-edged comment about my own union, which you kindly represent, they have not been at the forefront of trying to allow data to be merged from different sources, which would allow for better data outcomes in future crises. And if you could take back to your distinguished clients that recommendation, that they think about that seriously, I'm sure that that would be a very useful outcome.
Thank you, Professor.
Not sure you expected that.
Thank you.
Right, Ms. Hannett.
Professor Whitty, I appear on behalf of the long COVID groups. My lady, counsel to the inquiry, has very helpfully put many of the questions or topics that we wanted to put to Professor Whitty this morning, and so I was able to reduce the number of questions considerably. First topic, Professor Whitty, if I may, deals with recognition of long COVID. In your oral evidence in Module 2, you accepted that the evidence of long COVID was not in any way uncertain by October 2020. And you were asked questions this morning about those with long COVID having their symptoms disbelieved by the medical profession. Do you agree that the prompt public recognition of long COVID in 2020 by you would have prevented or ameliorated the delayed diagnosis and disbelief of long COVID sufferers and helped individuals protect themselves and their families from some avoidable harm?
Well, I hope that the fact that I set in train in, I think, June of that year, the first systematic review of it and tried to accelerate research so that we had an ability to have an evidence base is evidence that I, in a sense, fundamentally agree that it is important that it is identified and acknowledged. But I'm slightly puzzled if you're implying that I was not aware of it and making it aware to others, because
No.
my hope is that I was doing so as fast as I got information myself.
Professor Whitty, the question was whether or not public recognition, perhaps in a press conference or otherwise by you in summer or autumn 2020, would have assisted those long COVID sufferers who were disbelieved by medical professionals. If you, as the Chief Medical Officer, had identified the existence of long COVID at that stage.
I can't, and I genuinely can't recall when I, in a press conference, first talked about it, but the reason for dealing it within a professional group, and you're asking about professionals, I was certainly trying to ensure that at a professional level this was something which was addressed at a relatively early stage after this was first identified.
Professor Whitty, if I can move on to research into long COVID. Professor Breitling and Dr. Evans state in their expert report on long COVID there's an urgent need for further clinical trials testing both pharmacological and non-pharmacological therapies for adults, children and young people living with long COVID. Do you agree?
I do.
And as we've heard this morning, the NIHR has put out 2 funding calls into long COVID, the first in 2020, the second in 2021. There hasn't been any new NIHR funding for research into long COVID since 2021. Professor Breitling and Dr. Evans say that the research, which they identify as urgent, should be supported by dedicated national research funding. Do you agree with that?
Well, I think there's a difference between new research calls and continuing research funding, which is continuing in the UK and elsewhere.
Well, Professor, there's only one national funded research project into pharmacological interventions, for example. Do you accept that further research of that nature, for example, should be funded by national funding?
One of the problems for research into long COVID, and I'm going to give it a technical answer, apologies for that, is that simply randomly firing possible treatments into the system is never a sensible idea. So you've got to have a strong evidential basis for why you're doing either repurposed old drugs or, in due course, when we understand the biological foundations of the different syndromes of long COVID, actually designed for long COVID specifically. If you don't do that, the risk is that you actually do more harm than good, because all drugs come at a side effect cost to the individual. So I think the question about when is the right time to do therapeutic trials in terms of your underlying understanding of the epidemiology and biology of diseases varies very significantly, and it does with long COVID itself. Also, the UK is not the only country which is doing research, and this is an international effort, and I've talked about some of the discussions we've had with others. That's not to say that we should not continue to do therapeutic trials when there is a good reason to do so, but when you do a therapeutic trial which has no biological basis in the view of disinterested observers, the risk is you either cause actual harm because you're using treatments which have limited chance of success but a reasonable chance of side effects, or you make the field more difficult for subsequent studies and more appropriate treatments. I realise that's a technical answer, but it is an important technical answer.
Final topic then, Professor Whitty, given the time that I have left, planning and monitoring of long-term sequelae. In your witness statement, your evidence this morning, you accept that the initial planning for COVID-19 didn't take any account of the long-term consequences, i.e. of long COVID. You also accepted that the possibility of some chronic sequelae was accepted, but the nature and scale of those was not foreseeable. Given that the possibility of chronic sequelae was accepted, do you agree there should have been surveillance of that from the outset of the pandemic, just as there was of the acute effects of COVID-19?
I think it's difficult to know how you'd have picked it up in a different way to how it was picked up as it was picked up. I mean, people who had severe infections and ended up in hospital generally are followed up when they leave hospital. That's a normal clinical practice. And to that extent, they would have been picked up at a relatively early stage. I think that the bit which was the more surprising was the degree of disability that long COVID caused people who had had a mild or moderate initial infection. The problem there is it's not really clear how you could have put in place, not knowing what the symptoms were or who would be affected, an appropriate sampling mechanism, particularly in the first wave, where the great majority, I would suspect, of people who had COVID of a mild sort were in fact not diagnosed, because getting diagnostics at that stage was much harder than it was later on. So actually knowing who had COVID was really tricky at that point. This is not saying I disagree that we couldn't probably have done something better than we did, but I think it's not one of those ones where you look at it and think, well, it's obvious that's the thing we should do. I think it would have been quite hard to do for the non-hospitalised patients. For the hospitalised ones, as I say, I think a mechanism is relatively straightforward.
Thank you, my lady. I'll leave it there.
Thank you very much, Ms. Hannett. Mr. Pesney.
Professor, I ask questions on behalf of Mind, the mental health charity. The main contextual document I wish to refer to is the expert report for this module of the inquiry by Doctors Guy Northover and and Sasha Evans about child and adolescent mental health services. I hope you've had an opportunity to look at that report. It was produced after your statement, but I hope you've seen it.
I've read it with the important caveat that I'm neither a child health doctor nor a psychiatrist, so therefore I was reading it as an interested doctor and an interested public health person, but with that caveat in mind, yes, I read it.
Thank you. My first question relates to planning, specifically before the pandemic, in relation to the potential impact on the mental health of children and young people. You may recall that Doctors Northover and Evans record at paragraphs 10 and 162 of their report that there were no specific plans in place for mental health inpatient services in the UK's pandemic preparedness, despite the likely serious toll on everyone's mental health due to social isolation, anxiety, financial stress and grief.
I'm missing a lot of what you're saying.
I'm so sorry.
Stenographers too.
I'll go through it more slowly. There were no specific plans in place for mental health inpatient services in the UK's pandemic preparedness, despite the likely serious toll on everyone's mental health due to social isolation, anxiety, financial stress and grief. And no consideration was given to the impact on children and teenagers who would face disrupted schooling and social isolation. Paragraph 162, Professor, is broadly to the same effect. Are Doctors Northover and Evans correct that prior to the pandemic, the COVID-19 pandemic, there were no specific plans in place for mental health inpatient services or other aspects of mental health care in the UK's pandemic preparedness strategy?
In broad terms, my view is yes.
Are you able to assist on the reason that there were no such specific plans for the mental health impact of the pandemic?
I think that as I think was laid out very clearly in Leadership's first report, the pandemic planning had many areas where we had gaps in our capacity. I want to be clear that I think there's a big difference between a plan and a capability. Actually, I think a plan is less useful because there was no way we could have told in advance exactly the mechanisms and routes and outcomes that would have happened with COVID. And some of the effects were direct from the disease, but many of them were indirect via the lockdowns, which were in themselves unpredictable because they weren't part of the plan. So I think that would have been tricky. But your general principle that we should take account of particularly inpatient services, I completely agree with. And that's for many reasons. But an obvious one is that many people living with mental health conditions find it particularly difficult to adhere to some of the very difficult things during COVID. And these are closed environments where close contact is often needed. So for many reasons, I think that is an area where we could reasonably do a lot better in any future area. So I'm agreeing with you in a rather long-winded way.
I'm grateful. Can I just quickly follow up on your distinction between planning and capability and ask you just to expand on what you mean about the importance of capability in this context?
So the big difference here is that a plan is basically to say if a pandemic hits, we're going to do the following: A, B, C, D, and E. Well, we don't know what kind of pandemic. Remembering that the last pandemic the UK suffered from of any seriousness was HIV, completely different. It had effects in mental health areas, but completely different to the current one. So I'm very unconvinced that a plan will necessarily help us. But having capabilities, having people who are trained duly in infectious diseases as well as in mental health, maintaining stocks of PPE that are available and appropriate in these environments, those all strike me as things we should be doing. They're capabilities, not plans.
I'm grateful. Would those capabilities include sufficient resources to meet potential needs arising during a pandemic, for example, from increases in children and young people with eating disorders, and the continuation of those surges post-pandemic, which you will have seen Drs. Northover and Evans have reported upon?
But I think that's two very different things. I'm a little cautious about having as a reason for a particular area of skill in the UK, or capacity in the UK, something essentially held in readiness for the next emergency. I think the chances that would be maintained over time are incredibly low. So I think even if it's desirable, it doesn't strike me as practical. I'm not sure it is desirable, actually. On the other hand, the surge in child and adolescent mental health demand that we've seen post-pandemic, which is on the background of an increasing wave before that. So it's not just caused by that, but I think it has been accelerated by that. And specifically, the impact on eating disorders of various sorts, I think is a very serious issue. And I think we need to have a very clear view on this. Is this something which is going to revert back to the trend line that was there before? Or is this something which has actually been a step change and which is now with us for a long period of time? And that has quite different implications as to how we configure services, in my view, over the next 10 to 15 years.
I'm very grateful. Finally, in relation to children and young people living in deprivation and the mental health impact of COVID countermeasures on them in particular, I noticed in paragraph 4.58 to 4.60, really, of your fifth witness statement, that you identified people living in deprivation being harmed by, and I'm quoting, the countermeasures to COVID-19 in a way that is greater, I've stopped quoting, in a way that is greater when compared to more affluent areas. And you said it was, in my view, predictable that there would be significant structural inequalities in the health outcomes for COVID-19, but it was not, in your view, entirely predictable which groups would be most affected, other than that broadly people living in deprivation tend to have less good outcomes from most infections and indeed most public health problems. Would a mental health impact on children and young people from disadvantaged areas fall into your broad category of a predictable effect, Professor?
I think it was unpredictable before, but is entirely predictable once we knew what we were going to do. So I'll take the example of homeschooling. Homeschooling is a much harder thing to do for families which are dependent on physically going out to work, people who are living in much more restricted environments than it is in more affluent areas. It's difficult for everybody, but it was even more difficult in those areas. So insofar as schooling is one of the ways in which you can reduce anxiety and mental health issues in the medium to long term, which there is reasonably good evidence for. Therefore, as soon as it was clear we were going to have to do that, you would anticipate that this would be an even greater effect in areas of deprivation. Before you saw any data, you could be unfortunately confident that was likely to be the case, and indeed, in my view, it was the case.
I'm grateful. Thank you very much, Professor.
Thank you very much. Ms. Wirra-Atney, please.
Thank you, my lady. Professor Whitty, I'm over here. I ask questions on behalf of the COVID-bereaved Families for Justice Wales group. My questions are about DNA CPR notices and the use of frailty scores and the escalation of care, which you do not cover in your current witness statement. So I have to set a little bit of context as follows, so bear with me. At the outset of the pandemic, there was widespread reporting of unacceptable practices around DNA CPR and the use of clinical frailty scores in the escalation of care and ceilings of treatment. It was made clear to healthcare professionals through various guidance and statements that it was unacceptable for advanced care plans or DNA CPRs to be applied to groups of people or on a blanket basis, and that decisions must continue to be made on an individual basis according to need. So my question is, are you aware that nevertheless, the inappropriate use of DNA CPR notices continued throughout the pandemic?
So firstly, to give an extremely clear statement that I completely agree that it is unacceptable to have blanket approaches to this for multiple reasons, which I don't need really to spell out. It is not normal practice medically. It's not good practice. I am in favour of advanced care planning, to be clear. Having the opportunity in advance of an emergency to discuss with someone rationally, with their families, what would you wish to do, is entirely good medicine. That's as all of us should be doing. And I want to be clear that those are two separate things. Blanket things, absolutely not. Advanced care planning is a very useful thing to do. I have not been involved in any of the areas which were testing whether there was any evidence of this, but I mean, certainly anything I've ever said would under no circumstances have done anything other than say I'm totally against blanket approaches to DNAR CPR. So I want to be clear about that.
Thank you. Just so you know, that the basis of that question came from the Parliamentary and Health Service Ombudsman witness statement to this inquiry in terms of the findings he has made on inappropriate DNA CPR practice. But the question I wanted to ask you was, given that there was an early flagging of this issue, what was done to monitor compliance with the guidance and to prevent inappropriate practices from occurring?
Well, I mean, I think other than the fact that I don't think any responsible body did anything other than say that's the wrong thing to do, it's making clear that this is not an area which I was immediately responsible for, and therefore this wasn't the area where I was leading. And that's not, if I'd been asked, I would have made a very clear statement as I've just made, as I'm sure every senior clinician would. And Sir Gregor Smith made the same thing yesterday in regards to Scotland, for example. But this wasn't an area I was involved in, and therefore I'm not able to give you any more advice than you can get from reading the Ombudsman's report and wider reportage on this.
I'm grateful. Thank you very much. My next question is about the use of various scoring systems as a risk assessment tool, such as the clinical frailty score, Isaric 4C, and you mentioned acute COVID in your evidence. The bereaved families group that I represent are concerned that there was some conflation between those sorts of risk assessments and a lowering of a threshold for the use of DNA CPR notices. That's one thing. And possibly related to that, but the converse issue is raised by Professor Lockie of the Resuscitation Council UK, who addresses misunderstandings amongst clinicians, conflating DNA CPR notices with the use and escalation, the use of DNA CPR notices and the escalation of care. So Professor Lockie also refers then to the RESP ECT process, RESPECT, in England, which he says has been introduced to mitigate such concerns, personalising care, and also ensuring alignment of treatment and personal values of patients. The question is related to the fact that there's no such rollout of RESPECT in Wales, and whilst it does exist in other nations. Would you agree with Professor Lockie that the absence of a nationally standardised process creates patient risk?
Well, I'm not going to comment on Wales because Sir Frank Atherton, I think, is coming to this inquiry on Monday, so I think that would be more appropriate that he addresses how Wales is addressing this. The general principle that there is the decision to have for a patient to decide, usually themselves with their families in an ideal situation, that they do not wish to have resuscitation is unrelated to do you want to go on to do major other forms of care. They should, you're completely correct, I want to reinforce this, be seen as completely different decision pathways. That just to sort of, again, in a sense, agree with you on that one. On the second one, I I think that there may be a misunderstanding about what Q-COVID is if people think that this could in any way have any implication for...
Sorry, I'm going to stop you, Professor Whitty, simply because my question was about respect and not about Q-COVID, and whether you think that the absence of a nationally standardised process would affect patient safety.
Well, you did mention Q-COVID, and I wanted to correct a misapprehension. I want to be clear that Q-COVID is a system for trying to ensure that people at the highest risk are aware of that risk. It is in no sense something that would be used for any kind of care decisions of the form you're talking about. I just didn't want that to lie on the record uncorrected. Yeah. Are there advantages to having national systems? There are advantages to having systems which are widely accepted within medical nursing and other areas. You want to have a systematic framework, and then you need to make sure that individual patients have an individual conversation with individual clinicians, or if they can't themselves, ideally with families or people who can represent them. So a national system is, and you know this, but I'm just reinforcing this, is very different from a national approach to who would get resuscitation and who would not. That should be an individual decision.
So I'm going to take it that that was an answer. The answer is yes to a nationally standardised process such as respect.
That is one approach to it. I'm not saying that's what any particular nation should do, but certainly there should be a systematised framework, in my view. It could be respect, it could be other forms.
I'm grateful. Thank you, my lady.
Thank you very much. Mr. Wagner. That way.
Good afternoon, Professor Whitty. My name is Adam Wagner, and I ask questions on behalf of the clinically vulnerable families. I want to ask you about two topics, please. The first is shielding. Professor Whitty, shielding was paused on the 1st of August 2020, and children returned to school about a month later. Did you or your office assess the risk to clinically extremely vulnerable children and clinically extremely vulnerable adults living with children of that double whammy in the timing of shielding ending and the school restarting?
Well, I mean, firstly, there was around that time, and I can check on the dates, but if you'll allow me just to say around that time, there was a decision to remove the great majority of children from the clinically extremely vulnerable list. And that was done on the basis that the risk to the children was now, we felt, solid enough that the risk was so much lower that the benefits to them of shielding, with all the disadvantages in terms of childhood development, and I think we've heard from Mind, for example, some of those that accrue if you don't have access to education, would be denied them with limited benefit given the increased physical risk. So the 4 CMOs wrote to parents about school starting again in relatively unambiguous terms at that time. And I would refer you to that letter if you want to see our views at the time. They were laid out to parents, laid out over about 4 pages. We wanted to lay out the arguments. But in a sense, those two decisions were both aimed at trying to support children and their development, accepting that the children were coming to very significant harms from some of the social interventions that were necessary during COVID to try and reduce the risks of the kinds I thought that Professor Fong so powerfully laid out. So that's the children's side. In terms of the adults, yes, consideration was given to this, and there was a lot of concern about what to do to maintain, firstly, the reduced risk among adults who were clinically extremely vulnerable, but also trying to reduce the impact on the lives of those living with them, and trying to make sure that those two aims, which are in some sense in tension, to the best of our ability, were balanced against one another. So that, I mean, I hope I realise that doesn't give you exactly the answer you wanted, but it's I think an accurate reflection of our thinking at the time.
Thank you. Was any thought given to a more gradual transition out of shielding, as they had in Scotland, rather than the sort of cliff edge of just ending it at that point, or pausing it completely at that point?
Well, I mean, shielding, both to go into it and to come out of it, was a voluntary issue. So as some of the data which has been shown, I think, from the ONS to this inquiry demonstrates, many people who were clinically extremely vulnerable chose, perfectly reasonably, to continue to do the things they had previously done. They did it on a more informal basis. So the cliff edge, as you put it, was in a sense a choice cliff edge for many people. Where it was a bit more problematic was around delivery of some of the services. But this, as you will recall, was a period when the incidence of COVID was much lower than it had been at the point that shielding was introduced. And as we've heard from some of the previous evidence, the downsides for people being in shielding were very substantial. So that was the judgment on which, that was the basis on which this judgment was made.
And just related to that question about children living with clinically extremely vulnerable family members, and a lot of people who shielded obviously lived with other people in their homes who are not being shielded and would go out into the community more, potentially contract COVID. Did you consider a design of the shielding programme, or might you consider, if you were doing it again now, that focus more on the household than the individual, so gave advice and support to all members of that household, how to support that ultimately and protect that clinically extremely vulnerable individual?
There was quite a lot of advice to households, actually, as part of the clinically extremely vulnerable shielded programme. So it wasn't that there was no advice. I think that would not be an accurate reflection. The difficulty here is the one that I've indicated. What we were trying to do was minimise the disadvantages of shielding for those who didn't need it, whilst maximising the protection for those who were considered to need it as part of the initially judgment by the senior clinicians and subsequently, more accurately, in my view, the Q-COVID system. And those, as I've said in my previous answer, there was some tension between those aims. There's no doubt about that. But that was true for many of the decisions taken during COVID, of course. There was tension between aims.
And just going back to the pause in shielding and in fact the end of shielding, might it have been desirable or possible to include some additional measures, mitigating measures, once shielding was ended? Thinking, for example, about at the time shielding ended, the airborne route of COVID was very clear. Requirements for better ventilation in public buildings, air filtration, that sort of thing. Might it have been twinned together?
I think we didn't deal with ventilation earlier in the talk, so I'm going to give a slightly longer answer to that because I think it's a really important point. I do think that one of the things that has come out of COVID is that we should take ventilation of public buildings in particular much more seriously. Sorry, that's a very good point that you've raised. Non-specifically. So that's for COVID, but it also for flu, also for RSV, also for many other infections. It also, incidentally, has an additional benefit for indoor air pollution, something I've written on in a previous annual report. So I think we should be taking indoor air pollution, indoor ventilation of public buildings a lot more seriously and probably more vigorously than we previously had. There is a slight rider to that, which I'm going to put on the record, which is there is a risk that can lead, if we're not careful, to reduced thermal safety. So elderly people are also at risk if they get cold. So what you don't want to do is have something which actually leads to good ventilation, but leads to very, very significant cold-related risk in the winter months. But that's a solvable problem in engineering terms for most public buildings, though not all.
My second topic is masks. You said you're not an IPC expert, as in that's not your background. Is that fair?
That's correct.
I just want to put to you a couple of points that the experts that this inquiry is instructed relating to IPC have made. Professor Beggs on the physical science said, from the evidence presented above, a consistent picture emerges, namely that face masks are likely to inhibit the transmission of SARS-CoV-2 in healthcare settings, and that respirator masks appear to afford superior protection to healthcare workers compared to surgical masks. And he also says more research is necessary, which I know you've also agreed with. Do you disagree fundamentally with any of those points?
I would put much more emphasis on the more research is needed than Professor Beggs would.
Yeah. And the IPC experts that the inquiry instructed, particularly Dr. Shin and Dr. Warren, agreed that the IPC guidelines should be updated to recommend routine use of FFP3. As a non-IPC expert, would you defer to that conclusion?
Well, firstly, my reading of their expert review was they also felt that the evidence was weak. and I'm happy to be corrected on that, but that was my reading of it. Therefore, I don't think they were saying definitively that that's what the evidence showed. This is an area where we're going to have to try and get some greater consensus, and I think some of the questions I was asked earlier I thought were very fair and to the point on this. I don't think, from where I sit, and I'm not an expert in this area, those who are experts in this area have yet reached a point of sufficient unanimity that making a move to something which is much easier, much harder to use, is an appropriate one. Until I'm instructed otherwise by people whose expertise this is. I would want to add an additional point. I would be very cautious about using FFP3 masks in the general population without fit testing. I think the benefits of that strike me as way further down even than the previous ones in terms of probability, and the downsides of them I think are quite significant. Doesn't mean people shouldn't if they wish to, but I think I wouldn't want to be implying that we're recommending that.
No, but it is possible for members of the public to be fit tested.
It is possible, and if they wish to, there's nothing to stop them doing that. But I think for us to recommend that based on the evidence we've currently got, I think that could well lead to people who actually are disbenefited by FFP3s for a variety of reasons, including communication, doing so. So I think it is sensible to leave it as it is at the moment until the evidence base is stronger.
And would you say the same about FFP2 masks?
In the UK, we've used FFP3 largely because that's been HSE guidance rather than for any other reason.
Yeah. And just on that topic of, you said you wouldn't recommend for the general public, but you said earlier that one of the things you change going back would be to give healthcare workers the choice of wearing FFP3 masks if, for whatever reason, they decided to. Would you extend that to patients and visitors to hospital? And I'm thinking particularly about clinically extremely vulnerable patients and visitors who decided they wanted to wear an FFP3 mask and it wasn't clinically contraindicated.
Well, I think, firstly, people are free to do what they want, and I would not wish that in terms of going up in terms of their protection. I think there's an interesting and difficult question for someone on the front door whose job it is to make sure everyone is wearing a new face mask. When faced with that situation, I saw one of your questions you previously asked. My view is I could see arguments on both sides of that particular argument, but certainly I think the principle that people should be able to use FFP3s if they wish to, and if it's not contraindicated by other considerations, it's just a matter of freedom of choice as much as anything else. But I'd go back to the previous comment that an FFP3 absent fit testing, and it's very much easier to access FFP3 than it is to access proper fit testing. It's not obvious that it necessarily produces huge benefit over any other form of mask.
And my final question, and linking the two topics of masks and shielding, do you think now that public advice on higher quality masks, combined with a swifter acknowledgement of the risks of airborne transmission, would have helped reduce the impact on the clinically extremely vulnerable of the very stringent shielding measures?
I certainly think that if we were running the way we did things again, we would have emphasised masking in general at an earlier phase of the pandemic than we did. I think that's very clear. And I think we'd have introduced surgical masks for everybody at an earlier stage within healthcare settings. What I don't think that I would go as far as to say is that the evidence is there for, I think when you say higher quality, you presumably mean an FFP3, and for the reasons I've previously said, I don't think I go that far. No. I don't think the evidence base is there to make that statement.
But what about...
I think you've asked enough questions. Thank you, Mr. Wagner.
Thank you.
Right, who's next? Sorry, I've lost my list. Who's on their feet? Ms. Sengupta.
Thank you, milady. Professor Whitty, I represent the Frontline Migrant Health Workers Group. To provide some context, our clients' members include two particular categories of health worker. First, outsourced non-clinical workers, not directly employed by the NHS, such as hospital cleaners, porters, security guards, medical couriers and taxi drivers, who are in precarious employment including 0 hours contracts, on low wages and includes ethnic minority and migrant workers. And second, migrant clinical workers, such as Filipino nurses whose visas prevented recourse to public funds and whose leave to remain in the UK was contingent on their continued employment. I'm just going to ask you about risk assessments. At paragraph 5.58 of your second witness statement, you referred to one of the roles of the Office of the Chief Medical Officer as being to assess which groups were most vulnerable to COVID-19. For the transcript, that statement was produced in Module 2 and is inquiry reference 184638, but it need not be displayed, thank you. Professor, were any of the following categories of health worker assessed by the Office of the Chief Medical Officer as being particularly vulnerable to COVID-19? First, low-income health workers.
I'm going to stop you at this point because, well, firstly, it would have been very useful to have had a bit of context for this, to be able to read the context in which I said that. I think it probably sits slightly outside what I actually think, and therefore I suspect it had a context around it. So can I just park that? Secondly, our job, insofar as we were trying to identify particular risks, I mean, I think I discussed earlier on that, for example, the Q-COVID system was the mechanism by which we did that. And that looked at multiple issues, and one of the reasons that, for example, it was highly praised by the Runnymede Trust and others was it did bring in things like deprivation and ethnicity in a way that other risk scores didn't, and that was very much something we wanted to do. But it was definitely not my job or that of my very small team to take every single risk group in the UK and say which individual bits of that risk were relevant. This is not in any sense to belittle the importance of the question you're asking. I fully agree with the question you're asking is an important question, but absolutely it is not the role of the Chief Medical Officer to do that, and it would be silly for me to start randomly firing out answers on something which it is very obviously not in my area of professional responsibility.
Professor Whitty, the reason I asked that question is because you refer specifically to the OCMO as being involved in conducting such assessment during the initial waves of COVID-19. But can I take it from your answer that you agree that it would have been helpful for those categories of worker that I mentioned, low-income health workers, precariously employed health workers, outsourced health workers, and migrant health workers to have been assessed as being particularly vulnerable to COVID-19?
I think actually what I would have preferred to have happened, and normally I don't stray into areas outside health, but because I've made this point multiple times in government and publicly, I think what would have been actually more helpful is to make the employment of people less precarious during COVID. I think that solves the problem in a much more sensible and fundamental way than trying to identify someone who's at high risk and then saying you're at high risk. So I think that now how that's done is very much not for me. That's an economic question. But I think reducing economic precariousness is one of my strong recommendations to my successors, including in the technical report I think that we wrote. I'm pretty sure we made that as a recommendation. I've certainly said that publicly many times.
Thank you very much. Thank you, my lady.
That's very kind. Thank you very much, Ms. Sengupta. I think, Ms. Munro, is you?
My lady, thank you. Many of the questions I had intended to ask Professor Whitty have been dealt with, and I'm grateful to Ms. Carey, King's Counsel, during her examination. So I just have a few further matters and some points of clarification, if I may. Good afternoon, Professor Whitty. My name's Alison Munro, and I represent COVID bereaved families for Justice UK. And as I said, Professor Whitty, just a few matters arising from your evidence and questions of clarification. Firstly, in relation to the issue of technical advice and NHS 111, in an early CAS alert on the 3rd of February 2020, the members of the public were advised, if they had been exposed to COVID-19, that they should phone NHS 111 and not be referred to emergency departments unless seriously ill. This alert also highlighted public health advice and guidance, including advice for travellers and those who had been to China, mainland China, etc. Question is this, in terms of your office, what involvement did the Office of Chief Medical Officer have in the development of that advice?
So at a high level, we had one important contribution to it, but in terms of the actual algorithms behind NHS 111, we haven't had any involvement that I'm aware of. Certainly, I've had no involvement in that. That's a technical area, an important one, not one for us. The reason for this advice, I hope self-evidently, was to make sure that individuals could access care, very important that the patients could access care, but also in a way that minimised the risk to other patients if this person was a particularly high risk of COVID, particularly early on, and also healthcare workers. So the important thing was to allow people to access care in an appropriate way that meant they could go, if they were at low risk of COVID, and it was assessed by that, to an ordinary place where they could be assessed. That would be convenient for them, mean that their other non-COVID problems would be dealt with. Recalling that at this point, the great majority of people who might have had COVID actually didn't. That changed over time. But if they did have COVID, that they could be dealt with in an area which would minimise the risk to other patients, to families, to relatives and to staff. So the logic behind it, I hope, is reasonably clear, but I think it's worth laying out.
Thank you very much, Professor Whitty. And you've answered my second part of that question in terms of your capacity of CMO, what involvement you had in that advice. Thank you. Second topic, preparation for autumn-winter 2020. It would seem, Professor Whitty, that as a result of reports such as the Academy of Medical Science report entitled Preparing for a Challenging Winter 2020-21, which was published on the 14th of July 2020 and which was endorsed, subject to a minor amendments, by SAGE on the 9th of July 2020, that it was known by the summer of that year that there was the likelihood of a significant wave in terms of infection in the autumn and winter of 2020. Now, Professor, we've heard in some often very visceral terms, evidence from bereaved families, and only this morning, the evidence from Professor Fong about the devastating impact of the second wave. My question is this: were you satisfied that sufficient steps had been taken in the spring and summer of 2020 by the Office of the Chief Medical Officer, and indeed you in your capacity as CMO, to prepare the NHS for that second wave, in particular to maximise infection control in healthcare settings and minimise healthcare-acquired infection, which was known to have been a significant factor in the first wave?
Thank you. So, firstly, it was, in my view, highly probable, and I said this from quite early on the pandemic, that there was going to be at least another wave in winter, and that was covered in evidence to the last module. It was Patrick Vallance who commissioned the Academy of Medical Sciences report. I co-commissioned it to some extent, but it was really Professor Vallance, now Lord Vallance, who commissioned it, and we were very aware of the risks to it. So the risk was fully acknowledged. Secondly, the main thing that was being done by Sir Patrick and me was around trying to minimise the risk of a very large pandemic in terms of government actions. That was the principal foundation of our work, recalling that there were only 3 senior clinicians in the Office of Chief Medical Officer, and a lot in NHS England. NHS England, remember, I also have no statutory responsibility for. So in terms of what could I do within the NHS, the answer is I can advise, but it's at quite one remove. We were, however, well aware of and very cautious of the risks of nosocomial infection within the NHS. fundamentally, the best way to deal with this is to reduce the amount of infection in society. That is by a very long way the biggest way to get around that, and all the other elements are secondary to that. So that's where we put the majority, in terms of my team, of our effort. Was the NHS prepared for it? Well, we were the NHS, now speaking as a doctor, who worked through in fact, I worked near the peak of the second wave. I'm very heavily involved on the wards at that stage. We were a long way away from being in a good place, and Professor Fong's evidence this morning, I thought, was very powerfully illustrated that, and incidentally illustrated why some of those who minimise COVID are so wrong. But we had learnt a lot, and actually some of the other evidence that I think has been or will be in front of this module demonstrates that the NHS, which is a learning organisation, I don't mean that in a kind of PAP poor corporate sense, but individuals within it learn very rapidly, I think handled the second wave, despite the fact it had a huge number of cases, a lot better. And that's because individuals in wards, in primary care, in other areas, mental health and many other areas, had learnt and did it better. But there was still a lot of nosocomial transmission. There were still many, many deaths, and the system was in many cases under extraordinary strain, as was described earlier. So I wouldn't in any sense want to be painting a falsely rosy picture, and indeed that was not my personal experience working in that environment.
Thank you very much. Asymptomatic testing, just one question in relation to this. Professor, in your Module 3 statement, and my lady for reference, it's INQ 000410237 at page 76, para 8.3. You recall that you wrote to Jeremy Hunt on the 18th of August 2020 about asymptomatic testing of healthcare workers, expressing the view that this was best implemented as part of a study, given the low incident at that stage. Then, some 13 days later, on the 1st of September 2020, you recognised in an email to Professor Powis and Professor Suhail that during an autumn-winter surge, regular testing of all patient-facing staff would be needed. Now, asymptomatic testing of all patient-facing NHS staff begins in the week of the 9th of November 2020. My question is this, Professor, given the known likelihood of the significant asymptomatic infection, the risk of asymptomatic transmission, and the likelihood of a significant imminent second wave, do you feel that sufficient steps were taken to ensure that asymptomatic testing of healthcare staff was initiated quickly enough?
It was pretty obvious that the advantages of asymptomatic testing in principle of staff. But there were two very major limitations and one additional reason we didn't want to do it across the board at an early stage. The first limitation was we did not know how frequently we would need to test to actually achieve the aim, which is to reduce transmission amongst patients and staff. And that could have been, once a week, could have been once a fortnight, could have been every other day. It wasn't clear. And having better information on that meant we would have a better targeted approach. Additionally, the PCR testing that was was available to us up to around about the end of October had two very major disadvantages. It didn't give an instant result. And secondly, some people could remain positive for many weeks after, in fact, they had probably become non-infectious. 6 weeks or more was possible, which in a highly stressed system, having significant numbers of healthcare workers or care workers removed from the system, despite actually not being infectious, but because of this problem, would have been a limitation. That was an important research question. Now, what changed? The third thing, however, was we did not have enough tests. And this was the biggest issue by some distance. I can read through, if you wish, but I'm sure you don't wish, and I'm sure her ladyship even more doesn't wish me to, exactly how many tests we had at various stages. But really going up until the end of October to do asymptomatic testing of all patient-facing staff, let alone wider NHS staff, would have been well beyond the testing capacity we had, even although we'd expanded it out. So it simply wasn't a practical reality. What turned this into a possibility and really transformed our whole management in a way which was only second to, but a long way second to vaccination, was the ability to do lateral flow testing, which was point of care. And that allowed people to have an immediate result. It allowed them to do it in multiple areas. And although the lateral flow tests were less effective in the sense of less sensitive than PCR, they actually correlated pretty well with infectiousness. So therefore, people could test themselves quite regularly and quickly, not just in terms of healthcare workers, but in a number of other environments. And that made possible a whole range of things that previously hadn't been. I did, however, before we had the lateral flow, I was nervous, and the email you laid out is an important demonstration of this, that we would get ourselves to winter wishing to be able to test people and without the capacity, and I wanted to make sure that was not a limitation. So I was saying, look, OK, we don't have the data yet and the rates are low now. That won't be the case in 2 or 3 months. Are we ready for that? Please, can you ensure that we're ready for that? So that was the logic about why those emails were being exchanged.
Thank you. It's a very thorough and full answer. My last topic was shielding. You've been asked a lot about that, and most of my questions have been dealt with. And it's clear from your evidence, we have an idea of your views on shielding, its logics, its effectiveness, and indeed its appropriateness or not in any future pandemic. But just if I may just come back on one point in relation to that, would you agree that the provision that there should have been a provision made from the outset as part of the shielding scheme for enhanced protective measures for CEV people accessing routine or indeed emergency health care, and that the absence of such measures was in fact a fundamental flaw in the shielding scheme?
Well, I mean, noting that the bit I said I wasn't so strong on being able to answer questions on was the operational side. I was responsible both for the concept, not personally, but in terms of I had a responsibility in the concept and the choice of who was most at risk by 2 different mechanisms. My understanding of this was that there actually was an attempt to make sure that there was easier access to a variety of forms of information for people who are clinically extremely vulnerable, in addition to help with things like medicines and other things, which was a fundamental part of the package. So I don't want to, without being able to quote chapter and verse, because this isn't my area of real knowledge. It was in fact done in a different department to the one I'm housed in. So I was much less involved even in sort of corridor conversations on it. My understanding is that there was actually some degree of support, but it may not have been sufficient. I don't know. That's not me saying that it wasn't sufficient. It's just me saying I don't know.
I understand and appreciate. Thank you very much, Professor Whitty. Thank you, my lady.
Thank you, Ms Munro. That completes the questions for today. Professor Whitty, yet again, I'm extremely grateful to you for all the help that you've given the inquiry and for the thoughtfulness of the responses that you've given. They've been extremely helpful. I'm sorry I can't promise you that we won't meet again. I will give instructions to the teams to limit the demands we make upon you and your office as best we can, but I think, as you probably guess, it's inevitable. I think we're going to have to ask you to come again. But thank you for everything you've done for today.
Thank you.
Very well. 10:30, Monday the 30th September.